before we get started, can I just quick poll the audience? How many spine surgeons are here in the audience with us today? Okay, good. So I'm going to ask you guys a question at the end as well. Okay, so as you said, I'm Dr. Arthur Jenkins. I'm a neurosurgeon, private practice, used to be full-time faculty at Mount Sinai. I'm presenting on some work that I started over 20 years ago, trying to find a better way of doing just about everything we do. So I have no material interest compared to doing spine tumor surgery. I do have other potential conflicts of interest if we were talking about other things, and I'm open to other conflicts of interest if somebody has a suggestion. In summary, the spine tumor world, initially, all we did was we tried resections. We found that they did terribly back in the 50s, 60s, 70s, and to just doing radiation. Patchell showed radiation plus surgery when you actually remove the nidus instead of just doing dorsal decompression that did better than radiation alone. So we want to continue that process. And it does make sense in general that why not do everything through a smaller opening than you would through a bigger opening. However, it has been said in the neurosurgical community at every major meeting on major platforms by the senior spine tumor surgeons, there's no place in spine tumor surgery for minimally invasive approaches, which counts as dogma. Dogma is by definition a commonly held belief. So does that make rogma a commonly held false belief? So why would I bother to do this? Why would I take on this undertaking, go against the dogma of very serious and senior people? The answer is if you have this spine tumor, to take it out, you need to resect, usually from a posterior approach, all these major primary biomechanical structural entities. You wind up having, because of the approach, to put all this major hardware in, which gives you an exposure about yay big. These big exposures are painful. They result in very long length of stay. They're highly morbid. People die sometimes just from the exposure due to complications of immobility, being in the ICU, being on ventilator, getting lots of transfusions. It's not a benign process. Why wouldn't we want to try to find a better way of doing this? So we did, and actually got to be so effective that I actually stopped, for the most part, offering big open procedures to my patients. So I had to go through the data warehouse at Mount Sinai, all done through the Institutional Review Board support, pulled other surgeons, so during the same time period, other spine surgeons were doing standard classic open approaches while I was doing this. And what is this? Well, you start with a 1 or 2 level spinal metastasis that's causing epidural compression. And then you either give the classic open, or you do a minimally invasive approach off to the side, take the tumor out, replace it with cement. This is a minimally invasive approach resulting in a tiny incision, the resection and replacement with cement that is anchored with a single small screw, usually from a surgical set. And these are the goal is to put this incision away from radiation source. You can see the gray areas, typical LINAC exposure. So you start with this structure where you've got the vertebral body tumor and the epidural tumor, and then we go in with the tube from usually in the side away from where the spinal cord has been pushed, resect all the bad stuff, put a single screw into the remaining bone, hack some cement in under direct vision, and get out. Not very hard. So we looked at the patients, the demographics pre-op, no difference. Same exact patients, not surprising. We looked at, would I have done a minimally invasive approach on this maximally invasive patient? What did we find? We found that not only were the surgical times profoundly reduced, the blood loss was interesting. You can see a trend towards reduced blood loss. We did have a few high blood loss cases. That was before we started embolizing all these patients pre-op. But we also found that post-operatively, they did better. They didn't suffer through a massive operation. We got great decompression and often did it much quicker than you could do for an open procedure. We were able to start adjuvant therapy because the tumor incision was far away from the radiation and it was tiny, so the chemotherapy wouldn't impair it. And they had profoundly fewer complications, none, in almost 30 patients. Now, my group had previously shown that of all the demographics that you can look at pre-op, including are there mets in the brain, are there mets in other parts, even in mets in the spine, Are there mets elsewhere? The only two things that predicted survival post-operatively, better than Tamita, better than any of the other studies that are out there, was their ability to ambulate based on something called Hauser Ambulation Index, and their degree of pulmonary metastatic involvement. Bottom line is, everything else you can treat, but lung mets, there's not much you can do about that, unless it responds very well to chemotherapy. So when we look at those things, you can see that survival is based upon the underlying diagnosis and its degree of dissemination pre-op, but also how well they look. So what we found was that, interesting, there's a trend towards improving survival at 1 year in the MIS treated group. That's the blue line above. But those that survived out past 1 year live much longer. I mean, more than double the survival of the patients who had a standard classic open procedure. So in conclusion, we found that preoperatively, the minimally invasive and the maximally invasive patients had almost identical pre-op markers, and they had non-significant 1-year mortality. They also had no loss of correction or deformity over time of the study. But we found that compared to open, that they had shorter operation times, shorter length of stay, shorter time to ambulate, better ambulation post-op, fewer complications, and longer survival. Did I mention longer survival? If you were the patient, which would you choose? These are my references. I want to thank you. If you want more interest if you have any interest in discussing, reaching out to practice, the one on the left, if you want to talk about the research, click on the QR on the right, also look at our social media. Now, I have a couple of seconds left. Of the spine surgeons in the audience, how many of you think there's no place in spine tumor surgery for minimally invasive approaches? Okay, it's unanimous. Thank you very much. Any questions?
From your table 1, it's a little hard to imagine that the two groups were identical. There was only 4 parameters that you showed us. I'm sure you compared them at many other levels, certainly failure to thrive, metastasis to other organ system, cardiac function, yada yada. All the stuff that we use to justify using minimal invasive surgery in all cavities, not just the spine. It's age, gender, race, and representation.
Yeah, actually, if you look at it, the age, we're slightly older. We operate in slightly older patients minimally invasively. The gender is what it is with a relatively small group. I'd love to get this done in a larger group. If anybody is interested in collaborating, I'm happy to discuss. The race, we didn't find any statistically significant. We also looked at whether or not this was a treatment effect, a technology, or something that had advanced. And it was the distribution between the time periods were identical. Obviously, with the end of the number of different types of tumors we approached, they were all, it's hard to say, but there was clearly no preference between the two approaches. And the SIN scores were pretty darn close, and even their degree of deformity was nearly identical. I mean, as far as the useful parameters, there was nothing, and these are just some of the records. There were no statistically significant differences between the groups pre-op.
Do you think that something like this would partially invalidate the SINS criteria for what we call this is an oncological spine problem that is unstable and therefore needs an operation? Does it mean just needs an operation, or does it mean needs a stabilization surgery?
I think that's the whole point, is the needing an operation and then choosing what type of stabilization you do. We did stabilization. This was a stabilized procedure. It was stabilized with cement vertebroplasty, essentially packed into the cavity, but it was not done with instrumentation. Right? What all spine surgeons would agree is the definition of instrumentation is putting rods in to provide external support around the spine, internal to the spine. So I think these are patients who they need an operation, and they do, once you take it out, I mean, these are currently seeing patients with bad bone, if you don't replace the bone with something, they likely will collapse. But fortunately, in our group, they did not.
I had a question for the 8 patients with myeloma or lymphoma. Did you know that diagnosis before the operation, or what was it about those patients that ended up requiring an operation? Those are things we generally try to avoid.
So these were patients specifically with MES with a change in the neural